So there are people who really want common topics, common practical topics, short things, not too much of research, just something which practically हमें कैसे काम करना है. Please, Amit, please stop. और 2-4 मिनट की बात करें तो कह सकते हैं.
Mr. Sab, how you manage to be at multiple places at the same time? We are not live.
Yes, so I would like to
workshop is happening, sir, simultaneously.
इको वर्कशॉप ही सही आपको इको वर्कशॉप करते हैं.
या कुछ बांग्लादेश का है.
Oh, I see. Good, sir.
do we begin?
अमित कितनी देर में करोगे? और 1-2 मिनट के बाद.
हाँ ठीक है. Okay.
8:35 or so. 8:35 or so.
Yes. Okay, fine.
People are joining. 60 have already had. Devarun, are we live?
Yes, sir.
And tried, if you are live, try to do it on, then, if you are live, then we can start, Amit. Because follow you.
Yes.
Amit has to start. Amit?
Yeah. I am on.
Yeah.
Am I not visible or audible?
You are not visible.
You are visible, sir. Your voice is clear, but
I'm trying to locate why am I not visible.
Yeah. Now you are visible.
Yeah.
Or the other ENT faculties, they both are there. Yeah, Dr. Anju. Yeah, okay.
Hello, sir.
Hi,
Hello, everyone.
Hello.
Thank you for inviting me.
Hi, sir.
Hello,
sir.
Bala.
Hi, sir. Thanks again. Thank you for inviting.
Amit, please start.
Sir, can we start?
Amit, you are unmuted now.
Yeah, I am listening.
No, but you have to start it. Just start it.
Okay. Hello, friends, and welcome to the NeoMusic webinar we are having. And it's a very interesting session today on Neonatal Airway Anomaly Symposium, and it is being conducted by a host of faculty who are very experienced in this field. We have from neonatology, we have Dr. Kiran More, MD, FRACP, AFRACMA. He is a neonatal senior consultant, head of the department at MRR Children Hospital, Thane, Maharashtra. Most welcome, Dr. Kiran.
Thank you.
It's very difficult to find him in India. He's most of the time abroad. So, and
Very much.
over to my co-moderator, Dr. Girdhar, who is a neonatologist from Chennai. I would request him to, Dr. Kiran, can you introduce the other two speakers from ENT, from your hospital?
Sure.
Who are guest invitee for this workshop?
Yeah, sure. So thank you again.
So before that, just a second, Kiran, I'm so glad both of you are here. Kiran has a vast experience of having worked in Canada, Australia, New Zealand, and now he has come back to India. Ghar Vapsi hai, and he is very much in India right now. Has worked in Middle East also. Girdhar is alumni of PGI and presently professor and head at Chettinad Institute of Medical Sciences in Chennai. Yeah. Kiran, please carry.
Sure. First of all, thank you, Amit, and thank you, Surendra sir, and Central NNF for giving this opportunity and allowing me to organize this workshops or symposium. And although like I am representing on the neonatal side, this workshop or this today's talk session is mainly uh, focused on airway anomalies. So our experts in these fields are the ENT people and not us. I'll be sort of introducing this topic and sort of alluding to the ENT assessment. So we have two experts, ENT surgeons with us today. Dr. Bal Gopal Kurup, he is the consultant and department in Department of Pediatric Otolaryngology at BJ Wadia. I was fortunate to work with him in Wadia, and also now he's also attached to MRI Children's Hospital, and with a very vast experience. And second is Dr. Anju Chaudhary. She's also expert in laryngotracheal experts, and she specialized in tracheal sort of reconstructions, management, tracheostomy, decannulations, and all those things. She's attached to SRCC and Saifi Hospital, and hopefully we might have her in MRI Children's Hospital soon. And so yeah, we really have both experts in the field who will do the justice of today's talk. And without wasting time, as I mentioned, uh, I will start off with my session as a neonatologist or a pediatrician who who encounter with such diseases. So when this symposium was thought of, the idea was to sort of cover the topic as a whole, but I feel the 1 hour is very short to do justice for this topic. We probably need a half day sort of a session to cover this topic, but we'll try our best, and I'll try to be very brief in next 15-20 minutes. I'll try to sort of give assessment how and when and how you suspect the airway anomaly and what are the things you go through as a neonatologist or pediatrician to assess the airway, and then refer to the ENT. We'll talk about the detail of assessment and the endoscopic finding and also the management part of it. I've got nothing to disclose. This is again alma mater BJ Wadi at the top where I was previously working, and at the bottom is the beautiful MRI Children's Hospital. I'm currently heading the NICU. So overview of this symposium, assessment and some common etiology which I touch base upon, and then investigation and endoscopic finding with Dr. Bala will talk about, and the tracheal management will you will talk on. So just to begin, I'll just show some of the videos, and some of these cases are jointly managed with by me and Dr. Bala in our Wadia NICUs. So just to start the talk. So you can see strikingly this baby who looks very comfortable, sucking nicely, but having quite marked sort of respiratory distress, and has been managed in the casualty in the oxygen hood, which I don't like, honestly, but has been kept because of the fear that this baby is going into the distress. But we'll talk about the assessment part and everything, what could be the cause. This is another one, baby. So again, kind of this thing, I'll not steal the endoscopic finding here, but very classical baby with some airway anomalies. This is just to stimulate you what sort of different presentations babies can have with airway anomalies. This is another one, a preterm who is on nasal prongs, which is completely off right now, but baby is showing marked sort of sternal recessions. Okay. So this is, and again, kind of a floppy laryngeal airways, which can present. So this is just to stimulate, like a lot of times babies do present with respiratory distress, but there are certain striking findings which actually alerts us to think about the airway anomalies and refer it to ENT timely so that it can be timely investigated and managed. So this is the whole idea of today's my talk. But whenever you have a baby with airway assessment, and you have to always do a very quick initial assessment that there is nothing life-threatening, you're dealing with it. A baby with stridor can actually collapse in front of your eyes. And even I remember in very much my first residency that I couldn't manage or intubate a baby who had a very much complete tracheal stenosis. So first thing, whenever you are assessing or dealing with a baby with stridor or a suspected airway anomaly, you have to identify if there is no life-threatening problem. So if there is inadequate effort, or there's an obstructed airway, or maybe is associated with circulatory collapse, if this all is present, then you have to call for help. You probably call the ENT or the anesthesia team backup, and you have to quickly secure the oxygenate and do bag and mask, and probably try and intubate and secure this airway before you go ahead and doing the detailed assessment. So this is always the sort of first thing you want to do in a baby with an airway. So now let's go through next 10-15 minutes. What are the way you can assess the baby's different airway obstruction, and how you can suspect and reach to a diagnosis. So there are a few things, and if you have a systematic approach, um, which starts from the history, quick assessment of the examination, and then going on to the investigation, then you will reach your diagnosis. So always history is very important. You have to know the timing of the onset of the obstruction. Then you have to look at what are the presence pattern and characteristics of the any abnormal breathing noises. And you focus on the nature of infant's cry, the associated respiratory symptom, and then also look at any associated feeding difficulties, and then anomalies associated with other systems, especially cardiovascular, neurological, or gastrointestinal. So first thing, timing of the onset. So again, ask the history. If you have a baby who's presented just at the time of birth, baby is born, and then suddenly the symptoms and stridor is present, then there are the topmost diagnoses are laryngeal wave, tracheal or subglottic stenosis, which is congenital, or congenital vocal cord palsy related to the birth trauma. These are the top three diagnoses which we should think about. And there, the important is to take a history and focus on the parental factors. So if there was any antenatal reduced fetal movement, which might point towards a neurological condition, if there is a fetal distress, or polyhydramnios, which again tell you there is a lack of sort of swallowing which is happening, then you want to ask history if there is a mode of what is the mode, and was there any difficulty in the delivery, or any forceps or any other interventions has been done. And then also in the antenatal scan, whether there was any anomalies which were already known, like cleft palate, mid-facial hypoplasia, craniosynostosis, or any cardiac anomalies which is associated. So these are the things you should think about. Now, onset few hours after birth, there the conditions are a little evolving, which some might get missed in first few hours and then present. So classical is the laryngomalacia, when you present when baby gets upset, and after when there are feeding difficulties, and then the stridor is noticed. There could be hemangiomas which may not compress initially, but then later on they sort of get enlarged and then present. Macroglycia again might be present but not detected, and then will present with tongue obstruction, or if there is a small chin Pierre-Robin sequence, there will be obstruction setting in few hours, or get noticed after few hours. Then you go to the next stage. Okay, you suspected this thing. Then you want to assess respiratory distress. So a lot of this time the babies do present with respiratory distress, or they're associated with some other respiratory symptoms. So you have to still assess what kind of tachypnea. So what's the respiratory rate? Or what type of retractions are there? Is there any grunt, or is there any cyanosis present along with this other symptoms? So how do you recognize that? So again, this is very basic. All of us, we know there will be signs of respiratory distress like tachypnea, nasal flaring, retraction, grunting, seesaw breathing, head bobbing, all those things. And all of this will suggest some kind of a distress, or a child is trying to put an extra effort to breathe. So tachypnea, again, a most common universal sign of respiratory distress, and could be a presenting sign of an airway anomaly as well. So baby is bit tachypnic and trying to overcome. There could be nasal flaring, which again shows there is an upper airway sort of resistance, and baby is trying to open up the upper airway to decrease the resistance, and that is manifest as nasal flaring. Or there could be retraction when the soft tissue collapses, and if there is an airway obstruction or any parenchymal lung disease causing the sort of lung collapse, then baby will start having intercostal retraction. And then because the lungs are collapsing, the baby will try to maintain the FRACB by creating a grunt. So baby tries to maintain the lung volume by closing the glottis and try to breathe against the closed glottis, and so that it creates a peep. So here, a very typical expiratory noise, which is grunt. So we all know that, and this can be manifestation of anything, but we have to make that assessment. And then as the obstruction sort of increases and there is an outflow obstruction, baby will start having a bit of a seesaw movement, rocking motion of the chest and abdomen. And there is, sort of sometime head bobbing will, so it progresses to intervertebral suprasternal retraction and head bobbing. And then baby is trying to get tiring out, and this could be sign of a impending failure, that baby is about to collapse. So you have to secure the airway probably for this baby, and it is fairly a late sign that these babies will sort of collapse. And then comes the important things, which are the abnormal sounds, which we already heard in the first videos. There could be stutter, which is like a snort or a sign of an upper airway obstruction, like a kind of a block in the upper airway, or there could be stridor, which is a kind of an inspiratory sound. So let's have some again examples of this. Now, maybe this is a classical one. Okay, so classical kind of a stridor. Another baby, this was a tracheoesophageal fistula, which was operated. And then there is a known thing that sometimes there could be an issue with a recurrent laryngeal nerve get sort of stretched or palsy. And this baby presented post-op with a stridor. So again, it is pointing towards an airway anomaly. Now this baby has got a little bit of a narrow chin, a kind of a Pierre Robin, and then actually when you flex the neck, the symptoms get worsened. So this baby classically again, the voice, this is post extubation, prolonged extubation, and then there is the voice is not there, and in between this baby tends to get a stridor. Again, this is a baby with Chart syndrome. And you can see as there is already sort of a intervention done for the upper airway. And again, this baby is having sort of intermittent distress along with a intermittent stridor. So this is again kind of a spectrum of symptoms these babies will present. And a lot of time the things are facing at you, but sometimes there may not be symptoms present all the time. So you have to really do the careful assessment. Then the next thing comes is the detail got of going into the pattern of differentiating exactly where is the type of the lesion is. And I'm sorry, this is a bit of a busy slide, but I think this slide actually summarizes the different sort of presentation and what sort of possible etiologies will be there. So if there is an upper airway obstruction starting from nasopharyngeal, oropharyngeal in the upper airway, then the symptoms will be stutter, sorry, and which is predominantly in the inspiration. And like the upper airway, the in crying, again, we know classically the corneal atresia, that classical is it may improve with crying, but not always case in all of the cases. But and in oropharyngeal, it will get worsen. So it will get worsen in the crying, and also get worsen in supine position and also with feeding. And this will be associated with muffled sounds, and there will be variable choking. So this is classically present in the Pierre Robin sequence. So either upper airway or a chin or smaller chin and the sort of different airway sort of arrangement. And then the other things will be below that, below sort of the pharynx will be presenting with stridor. So either hypopharyngeal or glottic anomaly, subglottic anomaly, tracheal anomaly, everywhere stridor will be there. In the upper portions, in the glottic specifically, the stridor is classical in the inspiration, but subglottic and in tracheal, you might have inspiratory or biphasic or a prolonged expiratory phase. So again, that will be you will be able to differentiate where the sort of the site of lesion will be. And again, classically, all this will get worsened with crying. They'll get worsened in supine position. They'll get worsened with activity and feeding. All of this will get worsened with that. And except for the glottic, where the cry will be hoarse, everything else the cry might be normal. And the again in glottic and pharyngeal, there will be cough. So again, based on these type of symptoms, you will know if it's laryngomalacia is a vocal cord problem or is a subglottic issue or a tracheomalacia. So again, this conglomerate of these symptoms will differentiate where exactly the lesion is and what is the type of etiology. And cry is very important. You know, the cry will tell you about where exactly the site is. If it's hoarse, or if it's not there, obstruction, especially post extubation, then we know it is probably some laryngeal swelling or edema. So it is probably glottic or subglottic level, and there will be history of prolonged intubation or difficult intubation. If there is no voice, aphonia, again it is probably glottic abnormality, high risk of difficult airway. So there could be paralysis or palsy or something like that. If the cry is weak, there could be oropharyngeal obstruction. A brassy cry, type of croupy kind of thing will be tracheal or distal airway related obstruction. And cough, if there is a constant cough present without any sort of other systemic signs, this probably suggests impaired central control, or there is a reflux, or there is an incoordination in swallowing, and there might be micro aspirations which are happening. So all these symptoms, associated symptoms, are also essential, pointing out what could be the possible etiology. Now, the associated feeding difficulties, again, if there is aspiration, reflux, such as choking, then possible vocal cord palsy or tracheomalacia. If there's impaired ability to feed, then because of the work of breathing, then again, tracheomalacia, laryngomalacia, subglottic stenosis. Now, laryngomalacia typically don't they still feed the comfortable one, but tracheo and subglottic stenosis, they might have difficulty in feeding also. And if the baby is not putting on weight, failure to thrive, there is possibly a oropharyngeal obstruction, and baby is spending a lot of energy on breathing, and that's why he's not gaining weight. So needs to be investigated. And then assessing other systems. So always, as careful examination, we always look for syndromes. So charge or any other Pieroban or any other sort of syndrome which might be associated with airway anomaly, like Downs with hypotonia. And then there could be certain congenital heart disease which might be associated with certain syndromes. Then vascular rings again needs to be suspected strongly and needs to be investigated. Or there could be tracheal hemangioma. So if there are hemangiomas anywhere in the body, then one might suspect for tracheal hemangioma. And in certain cases, then you need to do specifically echocardiography and CT. So this is 35 days old with presented with laryngomalacia, and there was a acute distress and stridor, and was managed with PEEP. Baby was improving. So basically, this needed the vascular ring was diagnosed on echo, but CT angio was required to know that there is a sling which is compressing the trachea, and then the intervention was needed. So this is just a summary of etiologies. Again, what we went through, and depending on where the site of lesion is, these are the common sort of issues which might be involved, and then we sort of hand over to the ENT to assess and do the further investigation. So I will not steal the show for talking about different sort of airway, and I'll pass on the baton to next speaker, Dr. Bala, to talk about what will be the different endoscopic finding in different anomalies and how do you investigate and manage these babies. So with that, I'll stop. Over to you, Bala. Thank you.
I'll share my screen.
Sure.
Is it visible?
Yes, we can.
Yeah, thank you, Dr. Kiran. I was fortunate enough to work with Dr. Kiran at Vijayawada till last year. So I'll confine my topic to just endoscopic findings in a neonatal airway anomaly. So I'll not get into the details again. We get calls for stridor, noisy breathing, snoring. The stridor can vary from a very mild stridor to something that is heard couple of rooms away. It can be sudden onset, it can be progressive, and at times it can be just a weak cry for which we are involved. There can be recurrent aspiration pneumonia. Calls can come for extubation failure, multiple extubation failure, and failure to thrive. Again, I won't get into details, Anything in the upper airway can cause different noisy breathing. If it's a low pitch grunting noise, it could be anywhere above the supraglottis. If it is a high pitch noise, it could be in the extrathoracic trachea or in the larynx, and below the into the thorax, it could be present as a wheeze. So what do we do in an endoscopic assessment? There are 4 steps. First, without any anesthesia, under topical anesthesia, we do a transnasal flexible laryngoscopy to evaluate the dynamic obstruction that might occur. Then we anesthetize the child, we give topical anesthesia, and we do a rigid bronchoscopy to see if there is any static obstructions from the level of glottis to the distal airway. Then we suspend the larynx, we palpate and look for things that are not visible, like a laryngeal cleft, if there is a stenotic segment in the posterior glottis, or if there is any fixation of the cricoarytenoid joint. Finally, we always examine the esophagus to rule out if there is anything that might be contributing to the respiratory pathology. So our endoscopy trolley has a flexible bronchoscope and or a laryngoscope, a rigid lens, our rigid bronchoscope as well as esophagoscope, our microlaryngoscopy instruments, tracheostomy tubes and instruments are ready, and our few mucus aspirators if we need to collect any secretions. So incidence of pathologies that cause stridor, the most commonest, as you all know, is laryngomalacia. So if there is anything that I want all of you to take as a message at the end of this, is that any stridor is not laryngomalacia. So once a person labels the stridor as query laryngomalacia, all the papers, all the residents, all the consultants just label it as laryngomalacia. So there are other common entities which might cause stridor. We'll come to that. Vocal fold palsy is a very common entity which is totally missed. They are not picked up on any imaging, so they need to undergo a scopy. We'll come to the other ones as well as we go along. We did a audit of the number of cases we did in 2022 for stridor. Out of the 155 airway assessments we did, the commonest was laryngomalacia again. There are different types. I'll come to it. The other commonest or the rarer ones will come to it as well. So what do we do in transnasal flexible laryngoscopy? If the child is agitated, we mildly sedate the child and we pass a flexible laryngoscope with no anesthesia or almost no anesthesia to assess the upper airway. So just a tidbit, the flexible laryngoscopes can be a fiber optic one or one with a chip on the tip. The clarity of the chip on the tip scopes are better. The one we have is a flexible, so you might find some grains in the videos I'll be showing you subsequently. So what is one of the first things that we come across? We try to pass the scope through the nose and we are unable to pass. So some very evident pathologies like aerania, where the external nose is absent. So that is very evident. We do not go ahead with a nasal endoscopy. But there can be some underdiagnosed entities like congenital nasal piriform aperture stenosis, wherein the nasal process of the maxilla is overgrown. And in such children, they present with nasal flaring and a lot of distress. Even a mild upper respiratory tract infection can precipitate their distress. So we ask for a CT in such children. Many a times we are unable to pass an endoscope through the nose. In a CT on an axial cut, you might find that the measurement between the nasal processes, the nasal process of maxilla might be less than 8 millimeter. But the funny thing is that the dimension does not really correlate with the symptoms that the child might have. Many a times, children with a very small aperture might not have as symptoms as a child who has a larger aperture. So basically, you look for other entities in the CT as well, like a central single mega incisor, which might be causing an obstruction. Rarely, if the aperture is less than 5.7 and the child is not amenable to conservative management, we go ahead with a sublabial approach and we clear the, we enlarge the piriform aperture. So once you're able to pass beyond the piriform aperture, there can be pathologies, anomalies that can cause mid-nasal stenosis, like in this child with Apert syndrome. So there is mid-facial hypoplasia, which can lead to a crowding in the mid-nasal portion. There can also be encephaloceles and large dermoids, which might be causing this. Commonest cause in the nose everyone thinks about is choanal atresia, but that is most of the times ruled out if you're able to pass an infant feeding tube. In case you are not, then the child, as Dr. Kiran rightly said, if the child gets better many times with crying, we suspect a choanal atresia, and we get a CT scan done in which you'll be able to see a bony as well as membranous stenosis. You create a neocoana and the child does better. Some rare entities like this neonate who presented to us with extubation failure, who had a nasopharyngeal teratoma. So again, you need an endoscopy to diagnose this. It is all children with an upper airway obstruction need not undergo a CT or an MRI. You can diagnose many things with just a uh, an endoscopy. So going down further, what are the laryngeal and tracheal pathologies that can cause difficulty in breathing in neonates? One of the highly underdiagnosed entities are pharyngomalacias. They are supraglottic mucosal collapse, as in this neonate who had very severe distress. As you can see, the larynx is reasonably okay, but the mucosa above the larynx, the oropharyngeal mucosa, with each breath is collapsing inside. Such children generally have some central nervous issues, or there can be some syndromes associated with them. It's very difficult to manage them. They present with stridor, recurrent aspiration pneumonia, feeding difficulties. Many of them do end up with a tracheostomy. Milder varieties can be treated with hypertonic saline nebs to reduce the secretion in the mucosa. A commonest cause of all striders is laryngomalacia. Nobody knows why it happens. We do not know the etiology, the pathology behind it. There are different hypotheses. Only divided it into 3 types. It's more of a surgical classification, so that it's easier for a surgeon to decide if what kind of surgical management is required. 90% of the laryngomalacias are self-limiting. They go away with time. But there are some unfortunate babies who get stuck on the ventilator or are CPAP dependent. So what is type 1? Type 1 is when the mucosa or the arytenoids are prolapsing in on inspiration. These children require only the mucosa to be trimmed for the breathing to get better. If the child requires CPAP or has recurrent pneumonia, then we advise the supraglottoplasty, in which we trim the mucosa. What is type 2? When the aryepiglottic folds are foreshortened and it forms an omega-shaped epiglottis. So on inspiration, the larynx gets obstructed. So now what is type 3? When there is a retroflexed epiglottis and it gets sucked into the larynx every time the child tries to take a breath. This type of laryngomalacia requires an epiglottopexy, where the epiglottis needs to be sutured onto the base tongue. So these are not definite classification. It can present as different combinations, as in this. There is type 3, there is type 1, and there is type 2. So this child will require combination of all 3 when we surgically manage. What do we do in supraglottoplasty? So assuming that the child came with a type 2 laryngomalacia, we first cut the aryepiglottic folds. I'll be showing you a better picture. And then post-operatively, this is immediate post-op, this is how it looks. To give you an external perspective, this is how a child had presented to us. Was requiring O2 supplementation, had severe retractions post supraglottoplasty. The child put on weight, the distress had disappeared, feeding improved. In It can be done in multiple ways. It can be done cold steel, that like I had demonstrated here, or you can use a CO2 laser, in which the edema swelling, everything is comparatively much lesser. Here we had treated a child with type 1 laryngomalacia where there was redundant mucosa over the arytenoids. Second thing that you note when you do a dynamic assessment with a flexible laryngoscope is vocal fold mobility. So vocal fold mobility is again you cannot diagnose it in a child who's intubated, or you cannot diagnose it with the CT. You have to do a flexible laryngoscopy without any anesthesia. As you can see, in this child had severe distress and the arytenoids were fixed in the paramedian position. So you can have bilateral and at times you can have unilateral paralysis, as in this child. They generally present with weak cry or sometimes rarely with aspiration. So since our center is a tertiary cardiac care center, any child who undergoes aortic surgeries or any PDA surgeries, if they present with weak cry post-operatively, we do suspect left vocal fold palsy. The next entity which we look for in dynamic assessment with a flexible is tracheomalacia. I just want to share a case with you. This baby had multiple extubation failures. So the child underwent a CT without our knowledge. There was an endotracheal tube in situ, as you can see here. On the CT, everything looked normal. The endotracheal tube was in situ. The distal airways looked reasonably well. But still the child was not getting extubated. So we were given a call. We went ahead with a bronchoscopy. We found that there was a lot of injury to the larynx and subglottis due to multiple extubations. There was a lot of edema in the subglottis, injury to the subglottis, and there was a vessel compressing the middle trachea and was causing a near total obstruction of the trachea. My point being, you cannot diagnose this on a CT. You will require an endoscopy in such cases. What do you do when you find a vessel? So there's another neonate who had presented to us with CPAP dependence. The child also had congenital cardiac issues, a large VSD. So on bronchoscopy, we could see that the distal trachea, as you can see, the anterior and posterior walls are kissing each other. It was almost completely obstructed. So we got a CT done. Again, we found a vessel compressing. It was, I think, the brachiocephalic trunk and innominate artery. So we discussed with our CBT surgeon, and they went ahead and did an aortopexy. So once the aorta is pulled up and sutured to the sternum, you can see there's the same child after 3 months. The lower airways have opened up. So this child could be sent home, and the child is currently doing well. So what is the second step in our endoscopic assessment? We do a rigid laryngotracheal bronchoscopy, wherein we put a rod lens to check for any static obstructions. One of the commonest thing is subglottic stenosis. Now, subglottic stenosis can be congenital as well as acquired. So, in a neonate with any glottic or subglottic pathology, if there has been a struggle in intubating, the pathology might lead to a lot of injury, and the child might present with acquired stenosis. Even a congenital subglottic stenosis, if it is of the milder version, say grade 1 or grade 2, which I'll be coming to, and there has been some trauma during intubation, can end up with an acquired or a mixed subglottic stenosis. This child had a hypertrophy of the subglottic mucosa as well as elliptical cricoid. This child presented with severe distress to us. We did a flexible, the vocal folds were mobile, but we found that the previous attempt had led to injury in the subglottis along with a grade 3 stenosis. Also, this child had another secondary airway lesion. The reason I'm showing you the entire video is we had to pass a smaller scope. We had to go beyond and assess. In the distal airway, we found that the child had tracheomalacia as well as a pig bronchus, where the right upper lobe bronchus was originating from the main trachea. significance of this is that if the child only had pig bronchus, you try to intubate, the endotracheal tube might end up in the right upper lobe bronchus and might have distress. So again, coming back to subglottic stenosis, different grades. Grade 3 and grade 4 might require urgent surgical intervention. Grade 1 and 2 might present with repeated croup-like presentation at a later stage, but initially with mild distress and feeding difficulties and failure to thrive. So lot of our scopies are extubation failures because of multiple things. We get extubation failures due to a lot of injury to the glottis and subglottis. Neonatal cartilages and the airway can take a little bit of beating, but with inexperience and the improper instrumentation, there can be a lot of injury to the airway neonates as well. So the injury can be mild, there can be granulation tissue, there can be perichondrium of the cricoid, which can be exposed, there can be degloving injuries. Sometimes the injury is way above the larynx in the posterior pharyngeal wall. Sometimes there can be tunneling. Any shoving of the tube can cause a tunneling through the upper airway. And at times, if the baby is not adequately sedated and the tube rubs against the larynx, can lead to a lot of granulation tissue, which can cause trouble. What are the trouble we face? I'll skip this slide. So what are the troubles we come across? It can lead to cicatrization. So the child can present with post-extubation stridor. Very classically in the second or third week post-extubation, there can be early fibrotic changes that can be seen there. So what do you do when a child presents to you like this? Initially, decades back, it used to be do a tracheostomy, and then deal with it. Nowadays, we try and not to give a tracheostomy to the baby. We lyse these fibrotic tissue. We dilate them. You can use a balloon. You can use a laser. You dilate them, and then we give steroid injections locally. And this is the same child after 2 weeks. So we could salvage this child. Sometimes you find just a single web at one site. In such cases, we use a balloon to dilate. We use a balloon to dilate the subglottic stenosis. Immediate post-op might look something like this after dilatation. We again give steroid injections locally. This is after 2 to 3 weeks, the same child. It looks inadequate, but the child is doing much better, and these children generally require multiple attempts. If the cicatrization is much harder, there are other ways to do it with laser or coblation. Now, post cardiac surgery, there are some very special situations you come across. Sometimes you can have some anomalous vessel which was not missed on a CT. They can just pop up post tetralogy of Fallot or some other surgery. This was a child post tetralogy of Fallot had an engorged vessel in the lower trachea, which was going in between the trachea and the esophagus. Suddenly popped up after one of the corrective surgery. So these children also might require scopy, post cardiac children. And also remember, any cardiac child with a pulmonary artery sling. Pulmonary artery sling is almost always associated with a complete tracheal ring or a long segment tracheal cartilaginous stenosis. So they need to undergo a simultaneous surgery of the sling as well as the cartilaginous stenosis. Otherwise, they end up getting stuck on the ventilator. Cystic lesions of the airway are quite common. Recently, Dr. Anju would agree with me. We have been getting a lot of children with base of tongue cysts. They present with severe stridor. Dr. Kiran and us, we have also managed a few base of tongue cysts at Vadia. On initial scopy, there is a huge cyst. I would like to give a message. If ever you come across a situation like this, you find a cyst which looks transilluminant and you are unable to see the epiglottis, just aspirate the cyst so that you can secure the airway and the cyst can be dealt with later. There are no masses which present like this in children, in neonates especially. It's almost always a vallicular cyst which obstructs the view of the epiglottis. As you can see here, you puncture, it's a sterile fluid. Even if the child aspirates, it's fine. There might be very minimal bleeding. Once you secure the airway, the child uh, can be dealt with later. There can also be cysts below the level of larynx, like this child with subglottic cyst. This neonate presented with a paratracheal cyst. So the cyst had completely collapsed the trachea. The child wouldn't get extubated. Unfortunately, the parents didn't agree for a resection anastomosis, so we had to do away with the marsupialization, which is not the procedure of choice. But luckily for the child is still survived and is doing well. And the notorious cyst that presents is saccular cyst. So the cyst which forms in the ventricle of the larynx, they are very notorious to recur. They many times are not amenable to endoscopic procedures and might require an external surgery. So vallicular cysts, they can be handled with laser, cold steel. We use electrocautery. You can use coblation. You basically remove the entire cyst and you cauterize the base. They tend not to recur if you do a good job. Most of these vallicular cysts, they have associated type 3 laryngomalacia, wherein the epiglottis is compressed congenitally, which leads to a floppy epiglottis. So once the cyst is removed, we do epiglottopexy, wherein we suture the epiglottis onto the base tongue. This is the post-op result. This is the pre-operative result. Airway infections are quite rare, but you can have children with weak cry. And if they have been getting a lot of Budecott nebulization, they can have candidiasis of the larynx. Recurrent respiratory papillomatosis is quite rare in the neonatal period. They are generally seen in the low socioeconomic status, as the his human papillomavirus is transmitted during through the birth canal, and most of the times they present with a weak cry. This was a neonate who presented to us with a weak cry. We took a biopsy. It turned out to be a papilloma. Tumors are very rare, but in children we have come across embryonal rhabdomyosarcoma of the subglottis, in which we ended up taking a biopsy. We had to send the child for chemo. And there are rarer still spindle cell tumors which we have found in the bronchuses, which might lead to isolated collapses and need for repeated admissions. Subglottic hemangiomas are another common entity which are totally misdiagnosed. Any segmental cutaneous infantile hemangiomas, especially of the beard region. Any child with the hemangioma of the beard region, you need to scope them. You need to rule out that they do not have subglottic hemangiomas. The hemangiomas generally present towards the late end of the neonatal period or in the second month, because these children present with distress. Many of them get intubated. It leads to trauma, and then they present with acquired subglottic stenosis to us. So something to keep in mind. This is an interesting case. This child came to us with recurrent neck swellings at around 1.5 months of age. The parents had gone to multiple hospitals. They got USG done for the neck swelling. Sonography might not diagnose subglottic and neck hemangiomas. So we got an MRI done. The MRI was very classical. MRI showed that you can see the MRI here. You can see the subglottic hemangioma as well as parotid hemangiomas. It was not a silidinitis, and the child was treated with propranolol. So post propranolol for around 3 months, this is the child pre-propranolol, and this is the child post propranolol. The hemangiomas had almost shrunken to half the size. Just to give a visual perspective, face syndrome, children can present with extensive hemangiomas with ulcer over the face. Post 2 weeks of propranolol, you can see it's a magical improvement in such children. there are very rare lymphovascular malformations that can present. They are very difficult to treat. Many a times, larynx and the entire airway is involved. As you can see here, the entire trachea was involved in this child. And in this neonate, the epiglottis, base, tongue, trachea, the neck, again, they do very poorly. They have a lot of feeding issues. Even post tracheostomy, these children don't do that well. Glottic webs. Glottic webs are actually quite rare, but one association with a syndrome I would like to put across. Any grade 1, type 1 Cohen's classification webs that you come across, they generally come in DiGeorge syndrome. So if any DiGeorge syndrome child has a weak cry, look for grade 1 webs. And anything less than type 2 is amenable to laser treatment. Anything more than 2, that is 3 and 4, there is always a cartilaginous component. They require an open surgery. 2 and 3 might present with aphonia and respiratory distress. They cannot be intubated, especially type 4, you cannot intubate. They need to undergo a tracheostomy. Next comes suspension microlaryngoscopy. Suspension microlaryngoscopy, you have to palpate. So another underdiagnosed entity is children who present with recurrent aspiration pneumonia. You have to palpate the posterior glottis. As in this child had presented to us with multiple admissions around a month and a half of age. So on palpation with a right angle, you can see that our right angle is going beyond the level of the cricoid cartilage. This was a type 1. This one is a type 2 tracheoesophageal cleft, laryngotracheal cleft. It was going way beyond the cricoarytenoid joint. Type 3 and type 4 are again they present with stridor aspiration. They get intubated, extubation failure. So this child, you can see we had done a tracheostomy. This is in almost till the upper, the entire upper extrathoracic trachea was involved. And sometimes you can have type 4. Type 4, they do not survive. So we had to do this bedside this scopy. You can see that the endotracheal tube is in situ, and the feeding tube is right next to it, right here. As you go in deeper into the common esophagus and the trachea, after one point we have gone beyond the endotracheal tube. You can see the Ryle's tube is lying within the trachea, and this is a carina. This is a right bronchus, this is a left bronchus, and the feeding tube is going through the carina into the stomach. They do not survive. It's a very extensive anomaly. And rarely, again, another fatal anomaly that we come across is laryngeal atresia, wherein there is no larynx at all. It's completely atretic. One of the few times where you have no choice but to do an esophageal intubation. This is the same child. You can see bubbles coming out of the esophagus. Post esophageal intubation, the child's saturation picks up. Again, very difficult to explain to parents and treat. The next step in the endoscopy is doing an esophagoscopy. So this was a child post TEF, came to us with multiple aspirations in the second month of life. The child was not gaining weight, so was in the NICU. The neonatologist suspected that the fistula must have opened up. So we put our endoscope through the fistula. The fistula was okay. There was no leak through the fistula. We did a dye study as well, which was normal. Then we went into the esophagus. And there was complete stricture. So that was leading to recurrent aspiration. There was a small, minute hole. We couldn't even pass an infant feeding tube. So the child had to undergo multiple dilatations. So aspiration can occur with other esophageal anomalies like an H fistula. So if there is repeated aspiration, we look for a fistula which is much higher up. In the previous video, you must have seen the fistula's opening is much lower down toward at the carinal level, but this one is in the mid trachea, in the lower neck almost. In such children, what do? We try to cannulate such children. We put a ureteric catheter through the H fistula, and then we loop it around through the esophagus. So we loop it around. This is a tracheal opening, and this has come out through the esophageal opening. So it becomes very easy for us to identify during surgery. This child we operated, you can see that the fistula was seen between the trachea and esophagus. It's a small surgery through the neck, through a neck incision itself. The child does not need not undergo a thoracotomy. Sometimes there can be injury to the trachea during thoracotomy, during a tracheoesophageal fistula surgery, and can lead to a tracheal stenosis. This child unfortunately had a tracheal trauma, but the pediatric surgeon was capable enough to suture the trachea, and we could salvage the child. Although the child required a couple of dilatations, the child is doing well now. Sometimes there can be googlies. So this baby was around 5 months, but since neonatal period, multiple admissions with respiratory distress, and the X-ray classically showed left lower lobe emphysema. So they were not willing for a CT initially, so we did a scopy. In the scopy, I was happy to find that there was an H fistula, but that wouldn't explain the child's emphysema. The child also had a cartilaginous stenosis. So then we put a smaller scope. We went through the cartilaginous stenosis. At the carina, we found that the right bronchus was much bigger than the left bronchus. So then we thought, okay, let's see where this H fistula is going. So we tried cannulating the fistula. We cannulated the fistula, but we couldn't find the end of the fistula's opening. So then finally, we put the scope into the fistula along with the ureteric catheter, but we couldn't reach the end. Almost 4 to 5 centimeter inside, we still couldn't find the esophagus. So then again, we convinced and we got a CT done for the child. Unfortunately, I do not have the CT images, but what it turned out to be was an anomalous left lower lobe bronchus, which was opening from the main trachea. So there are n number of anomalies which you might discover during endoscopy. I just want to give a small few things about some syndromes. Pierre-Robin sequence can be non-syndromic or syndromic. In such children, we see if the child has dependence on ventilation, non-invasive ventilation, we do a flexible scopy and we look for the laryngeal inlet. As you can see, initially on scopy, the laryngeal inlet is collapsing in Pierre-Robin sequence. Then we take a suture through the tongue. We take a suture through the tongue and we pull the tongue up. As you can see, we have done here. We pull the tongue up, and at the same time, we check through the flexible endoscope if the larynx is opening up. So the larynx is opening up here. So now we know if we do a tongue lip adhesion for this child will do well. So we go ahead with the tongue lip adhesion, wherein the tongue is sutured to the lower lip. Some few associations, Apert syndrome, as I mentioned, can have mid-nasal stenosis. Achondroplasia can have multiple airway issues in the upper as well as lower airways. Charge syndromes can present with congenital subglottic stenosis. DiGeorge syndromes can have anterior glottic web. Down syndrome can have multiple issues, including tracheomalicias. Even Prader-Willi syndrome, if a child presents, can have tracheomalacia. What is the take-home message? As I mentioned, all striders or noisy breathing in neonates are not due to laryngomalacia. So kindly do not write query laryngomalacia for any strider. Write it as strider under evaluation. So nobody is sure. We'll do an assessment and find out. So we should always try to get an airway assessment prior to an airway intervention, because once you put in a tube, we lose the ability to diagnose. Dynamic assessment of airway is necessary because as you can see, you cannot judge a dance show by looking at pictures or static images. In case of recurrent aspiration pneumonia, always rule out a laryngotracheal cleft by palpating and look for an H fistula if it is there, and always suspend and palpate for cleft. It is not a visual finding. And examine the esophagus. Thank you.
Excellent. Excellent. I think that was very comprehensive, Dr. Bala. Very, very well covered the topic. The show is not over yet. People can start putting questions, but we have one more speaker, Dr. Anju Chaudhary, who's a laryngotracheal expert. And again, she's consultant at SRCC and Saifi Hospital. Over to you, Dr. Anju, to cover the focusing on the trachea.
Thank you so much, Dr. Kiran. And I'm honored to be in the esteemed group of neonatologists and pediatricians here. I should applaud Dr. Bala for this extensive collection of cases, which has covered almost everything, all possible pathologies. I was asked to speak on neonatal tracheostomy care. So I'll share my screen. Is it visible to everyone?
Please go ahead. Yep.
Am I audible?
Yes, yes, ma'am.
Yeah. So my topic is about tracheostomy in the neonate, how to take care of it and decannulate. It's a vast topic because there are many things that should have been covered in between, like complications related to the tracheostomy, post decannulation complications, but I cannot concise everything. I'll keep it very clinical, which is very, very relevant to a neonatologist and the NICU people around. So I am Dr. Anju Chaudhary. Can you see the change of my slides?
Not moving. Can you move? It's still on the first slide.
We'll share again.
Can try using the arrow.
Okay. So now, yeah. So I work at these two places. This is Saifi Hospital and SRCC Children's Hospital. And I've been fortunate to be trained by Professor Philip Monier, who is a well-known pediatric airway surgeon from Lausanne, Switzerland. He's part of my team. He's also a mentor along with Dr. KK Ezi. We are fortunate to establish a department of airway surgery at these two hospitals, which is a new entity altogether. Now let's talk about neonatal tracheostomies. So everyone around here knows that the most common indications would be upper airway obstructions, children on long-term ventilatory tubes, prolonged intubations, or for pulmonary toilet. Uh, According to ENT surgeons and airway surgeons, upper airway obstruction accounts for almost 50% of the cases for which we do a neonatal tracheostomy, because these children generally present with various malformations, lymphomuscular malformations, cord palsies, or stenotic lesions, or dynamic obstructions of the airway. As we prepare for a neonatal track, we would always prefer doing it in the OR, because for an ENT or airway person, a neonatal tracheostomy is not a minor procedure. It's a major surgery in itself. So we would always want all our help and all armamentarium to be with us. So we would want to do it in an OR. But in an emergency, we would not mind doing it in the NICU, but we will need all the facilities to be arranged there. Important part here is the consent. The consent from the parents or caregivers is not just about the track, but it is also about its care. Because a neonatal tracheostomy is never a short-term tracheostomy. It is a long-term process, and the parents have to adjust to the new situation that has been given to them. So the consent has to be in detail. We would love to have an intubation tube inside. If not, then at least a laryngeal mask airway, or at least we should have bag mask ventilation to be able to do this procedure safely. Neck position is as shown in this. A shoulder is kept below the shoulder. A shoulder blade is kept below the shoulder of the neonate, and the head is supported by an occipital pillow, silicone pillow. We would love to have a team because, as I said, that the tissues are very small. The trachea and the great vessels are very close. Everything on palpation looks fibrous, and the lumen size is very narrow. So we would have to, if we have two experts in the team working together, the safety margin increases. Then we move on to the steps. I'll quickly go through it. It's usually vertical. We exercise this fatty tissue around because these neonates have a chubby neck. They have a lot of subcutaneous fat. So we excise it. Then we expose the trachea, and we take these stay sutures and make a mature stoma. So these stay sutures are proline sutures before incising the trachea. These are these are taken just besides that incision over the trachea. This is to help you guys from the neonatocide. In case of accidental decannulation in the first 5 to 7 days, it becomes very easy for you to pull up these proline sutures and put the tube back in directly into the trachea. These maturation sutures that we take, this is to suture the skin to the anterotracheal wall. For making this stoma helps in various ways. It prevents subcutaneous emphysema. It prevents leakage of secretions around. This will prevent in peristomal cellulitis. It will prevent accidental decannulations, and recannulation also becomes easy. So these are two important steps that we should take, and we should know that this is important to be done for all neonatal tracheostomies. Then we refer to a mobile airway card, which is an app, an Android-based app, or an Apple iPhone app, which gives the appropriate track tube size, which is important in these neonates because sometimes they are preterms. It is based on the weight of the neonate as well. So I request everyone to download this app. It's very simple. We can put in the age and weight of the child, and we get the right tube. This is how the tube is fixed on the neck. So these two are seen as the proline sutures, which are the stay sutures, which have to be labeled right and left and never to be twisted around. This has to be kept for at least 5 to 7 days till the first tracheostomy tube change happens. This is very important to prevent perioperative complications of accidental decannulation. Sometimes if there is mucus plugging and the tube is completely blocked, in a neonate, the size is around 3.2, or sometimes even smaller, 2.5. It can easily get blocked. In that case, we can easily remove this tube, stretch these two stay sutures, and put a new tube back in. Next step is to confirm the position. This we all know is by auscultation or by capnography. For us, it is also important to pass a flexible scope through the tracheostoma and see the distal end. Because we know that the neonatal airway is short, our tracheostomy tubes are not actually made to that length. So sometimes it tends to go into the right main bronchus, and hence for all these neonatal tracheostomies, we should try and pass this flexible scope. This also helps to see what size of catheter and length of catheter would easily pass to the tip of the tube for its suction. Then next, when the patient gets shifted to the NICU, every child should have this tracheostomy card with the patient's name, the size of the tube, the inner diameter, length, also the suction catheter and depth. This has to be filled by the ENT surgeon. Another important point is whether this child is intubatable or bag maskable or not. In case of accidental decannulation, if nobody is able to insert the tube back in, it is important that they read the chart and not try and attempt intubation if it's a case of subglottic stenosis, tracheal stenosis, or any difficult upper airway obstructive pathology. Also, we have to mention when the tracheostomy is due to be changed. Another important thing that we tell all the neonatal physicians as well as the staff, sisters taking care of the child, that this should be known to all. You have to always keep the child in a safe environment. In case of accidental decannulation, mucus plugging, or any difficulty in breathing that you notice, you have to check the area, stimulate the child, call for help. Always call for help. Even if the child is at home, this card is given to. You try and open the child's airway by head tilt, chin lift. Keep a pillow or towel under the shoulder. Start oxygenation. Even if the tube is partially blocked, you can still give some oxygen through the tube and also through the face mask. Whatever oxygen gets delivered, it's life. Attach a carbon dioxide capnograph to see whether it's actually a decannulation, it's a false passage, and then proceed to the next steps. Then the post-op care. This was actually established by the American Association of Otolaryngologists and Head Neck Surgeons in 2013 and the IPOC-G in 2016. That care of a neonatal tracheostomy is a multidisciplinary work which involves 5 specialties: the ENT airway people, a trained assistant, a NICU physician, a stoma nurse, and a speech language pathologist. I'll explain the role. Our role is purely surgical in the initial part of it, and then later during the tube change. The most important is the nursing care. Because they need to do the routine dressing changes daily or when it is soaked. They have to suction it every half hourly on day 1 and daily as and when it is blocking. They should know the diameter and length of suction. They should keep humidification ready. They should also be trained in emergency track care, and it is our duty to train our nursing staff in the NICU to do that. They also play an important role in parent education. So when they are taking care of such a child, they should allow the parents to be around and observe at least from a distance what they are doing. Next important thing is mobilization. Now, with recent studies coming up, they say early mobilization in a NICU child will help in better recovery of these children in neurological cases as well. There is obviously a risk of accidental decannulation, but with the methods that I've shown earlier, we can always try and prevent them, and training our nursing staff will help early mobilization of these children. Now, dressings, various types of dressings are available. They can be simple gauze dressings, these silicone dressings, or these silicone pads in case of a thick, heavy neck child. We can use the silicone pad. These prevents those macerations that occur because of rubbing of the flanges on the neck of the child. These cute little Velcro-based straps are available nowadays easily. We recommend them because they help prevent some skin markings, skin macerations posteriorly over the nape of the neck. Humidification is extremely important because these children are not breathing through the nose. So temperature regulation and humidification should happen through the tracheostomy tube. Various types of filters are available and should be used. If not, then at least a wet gauze has to be placed over the tracheostomy tube to help humidification. Now, this is an excellent chart that I came across. This contains all the different types of tubes that are available in the Indian as well as international market. For us, this Bivona is important. This chart gives us the internal diameter, outer diameter, the shaft length ratio, length in the neonate as well as the pediatric age group. So if we have this chart, we exactly know what tube is needed and what length of suction catheter will be useful for this chart. It's an extremely helpful chart. Next is sedation and analgesia. Analgesia from the NICU point of view, it is based on the state behavioral scale where they try to taper the sedation because we do not want the child to be extremely agitated, especially when the track is new. We also want him to have good amount of analgesia. So it has to be a balance between opioids, benzodiazepines, and neuromuscular blockade. For the first 1 or 2 days, we would want them to be deeply sedated, maybe paralyzed, but after that, we would want them to slowly come out of it. Nowadays, Dexmed, the drug, plays a very important role in early stoppage of neuromuscular blockages and all. So the recovery is better. Now, tube change. We recommend it to be done on the 5th to 7th day. These stage sutures obviously help us and anyone who's trying to change this tube. We can also have this technique called Seldinger technique or the railroading technique where we pass a small infant feeding tube through the tracheostomy tube and then pass it through the stoma and railroad it. This is to be done only if we do not have these stage sutures in some places. Then we can do it by this method. Now, silicone tubes are these better soft tubes as shown in this video. These can be changed monthly and they can be used for up to 5 months. However, the PVC tubes or the Potex tubes that are available in various companies, they have to be changed weekly. And their overall life is only for 4 weeks. So a new tube has to be kept ready with these children all the time, and one smaller size tube also. Now, the role of speech language pathology, it's really not very well understood in the Indian scenario, at least. But we should know that 1/3 of the NICU tracks will aspirate because they have some underlying neurological problem. And out of these, 2/3 will need an infant feeding tube. So the role of a speech pathologist is that they come in early. We call them as early as day 3 of life. They start giving them an orator or speaking valve on the tracheostomy tube. Sometimes the children tolerate well. Sometimes they do not. Then we try to create some kind of holes in the orator valve for an expiratory leak to happen, because it's known that around 74% of these NICU children will have some kind of phonation if an orator valve is given early to them. So this will improve the overall growth of the child, their coordination with the parents, their emotional tuned with the parents, everything will improve if we can give them some kind of phonation. It will also improve in their swallowing efforts, because an orator valve will create a negative pressure in the subglottic region, and it will eventually help in swallowing. The speech language pathologists also help in training the parents about taking care of the tracheostomy, about speech and swallowing as well. Hence, the role of speech language pathologist should be stressed in all NICU units. So this is the valve that we use, this is the Passy-Mayer valve. Now, when the child is considered for transfer from the NICU to the ward, we have to analyze the care proficiency of parents and caregivers. This is done by first training them by observation. The sister is doing it and the parents are observing. Then we have this kind of mannequin, which we give to the parents, on which they try to change the dressing, suction the tube, change the straps. Everything is trained on them. Then we show them recorded videos of how it is to be done. Then they start doing it for the NICU children under guidance of a trained nurse. Finally, they do it independently, and that is the time when they are ready for discharge. In special needs children who need ventilatory support, they have to be trained for venti settings as well. And all these parents have to be trained for advanced basic life support. This has to be trained by the nurse to these parents before this child is planned for discharge. This is extremely important. Now, all our children go home with this kind of tracheostomy card, and I recommend that this has to be implemented in all the hospitals who have neonatal units, because this gives the type of tube, the size of catheter that is to be needed. Also, this important point that whether this child can be bagged or intubated in case of an emergency. Also, an emergency equipment set has to be given to these parents before they go home, which contains same size tube and one size smaller, a suction machine, different suction catheters, normal saline, scissors. These seem to be very, very basic, but they are extremely important. And studies have proven that these emergency kits can actually save neonatal lives, especially after their discharge. So this is extremely important to note and give with the parents, along with an emergency contact name of an ENT person or a neonatal person whom they can contact directly. Now, I have created this short video to explain to parents of how to change this tube. I'll let it run. It's in Hindi. It's in Hindi.
I think the audio is not coming, but it's okay, I think.
Okay. Nothing at all, but it's written down. So I
Yeah,
can talk over
we can
this.
read it. Yeah. I think we all had the same issue. I think with the Strider also the audible sound was not there, I think.
Yeah. So I've kept a shoulder beneath this child's neck and extended the neck. So this is important to extend the neck, which opens up the stoma. Somebody has to hold the child. Then the strap is cut. And the tube is to be suctioned clearly, so that if there are any secretions distally, they are suctioned out. And then it has to be tied with 1 finger distance. It has to be a gap of 1 finger, so there is no maceration over the neck. Then this kind of dressing is made. Now this is the technique for suctioning. Always pinch the suction. Then mark it on your finger the depth of insertion, and then insert. And when you are suctioning, just loosen it, rotate it, and bring it out. This is the filter. So I show this so that the parents become more comfortable that we will be able to take care of the child. We'll be able to do this on our own. And this has to be forwarded to everyone in the family, all the caretakers, not just the mother, not just the father. next comes the complications. So 1/5 of all these pediatric trachees have complications, and neonates are twice more likely. This data is quite alarming, and hence we should all be aware of these complications. Most of it I have covered during my talk, like accidental decannulation, mucus plugging, local infections, how they can be prevented by improving the care of tracheostomy. Certain emergency measures that I just want to point out is that any patient who has a blocked tube, if we remove the tube, extend the child's neck and stretch the stomal skin, the child will be able to breathe through the stoma till you get a new tube ready. Sometimes in dire emergencies, where you're not in a situation where you're not able to intubate bag mask, you can apply your routine mask on the stoma, or sometimes the supraglottic device that you guys have in your NICU unit can also be used on the stoma, but the neck has to be extended and this has to be kept, the stoma has to be kept pated. So these are something that if we have seen once, in case of an emergency, we will always keep in mind that we can try these measures. Now, some early complications like bleeding, pneumothorax, and late local complications, I won't cover them in this session. I'll move on to the next part, which is decannulation. So there is a specific criteria for decannulation candidacy. Any child who is off ventilatory support for 3 months and shows no signs of aspiration, and at least has one vocal cord mobility documented on laryngoscopy, where there is no suprastomal granuloma in the distal trachea and there is no suprastomal or minor suprastomal collapse, is the candidate to go ahead for decannulation trial. So there are 5 key steps. The first is to confirm the patency of the airway. This is done by flexible laryngotracheobronchoscopy, which is shown by Dr. Bala, where we can see suprastomal granulomas or collapse. We remove them endoscopically. There can be associated tonsils and adenoids obstructing the upper airway of these small children. So they also have to be removed if they are partially obstructing, because 2 levels of obstruction will multiply the airway obstruction to a grade of raised to 4. Then we should remove the tracheostomy tube from the neck and put a finger or thumb over the tube and allow the child to breathe spontaneously while the airway is examined endoscopically to see for stomal collapse. After the child passes this test, we give this decannulation cap. We put a 3-number uncuffed tube. Then we give him capping trial for 6 weeks at home. If this is tolerated, then he is admitted overnight in the hospital for nighttime capping. This is because the parents do not understand what exactly do we want to see in the night, and most problems occur in the night. We should check for distress, stridor, retraction, desaturation, restlessness. Even restlessness is a sign that the child is not comfortable, excessive sweating, and we have to also see that the child doesn't need suctioning during that stay overnight. After he passes this test, in the daytime, the ENT would remove this tracheostomy and stab the stoma with this kind of adhesive dressing and observe the child for 20 minutes, and then keep the child stabbed for the next 24 to 48 hours in the hospital. After that, the stoma is left to close on its own. Most stomas close within the first 6 months. If it doesn't close and it comes back like a tracheocutaneous fistula, then there are 2 ways to deal with it. Either we freshen these edges of the skin and the trachea and let it granulate easily, or we do a surgical closure of stoma. After that, the child is asked to follow up after 4 to 6 weeks or 6 monthly until the stoma is closed. During each follow-up, we should check for dysphonia and dyspnea. Now, what is failed decannulation? When the child does not fall into any of these proper steps, we have to go back and check what was the obstructive lesion, correct that obstructive lesion, again wait for 3 months and check with microlaryngoscopy again, and then again go into that process of 6 weeks of capping and trial of decannulation. Now, in neonates, there is a special consideration to be given considering their very small size. So, I would like to say that the track tube that we try to use, the smallest one is 3.0 ID with a 4.2 OD. Now, tracheal diameter of a neonate for 6-month-old child is around 6 millimeter. So, the cross-sectional area occupied by the tracheostomy tube inside will be almost 50%. So, there is a high probability that with a 3-number tube, a child of 6 months will not be able to tolerate capping. As the child grows, at 18 months, the tracheal diameter becomes 7 millimeter. There's only 1 millimeter rise. However, the cross-sectional area occupied by the tube becomes about 36%. So then the child is more likely to tolerate this 3-number tracheostomy tube. Also, as we remove this tracheostomy tube, if we try to do it in the neonatal period, what happens is there is sudden doubling of the dead space, because now the child has to breathe from the nose to the tube and then into the lung. and hence there is trebling of the airway resistance which the child is not acclimatized to. Also, there is associated tracheomalacia with these children. Considering all these factors, we think of some solutions whether these children can be easily decannulated at an earlier age or not. So we try to use a 2.5 ID tube which has a 4-number OD. However, these tubes are not easily available and it's very difficult to maintain because if the parents have to suction it, they have to remove the cap and there is a very small mucus plug blocking it. It's very difficult to remove. Then there is something called as a fenestrated track tube that can be tried. We insert a tracheostomy tube number 3, but we create a fenestra by cutting a small oval shape with a blade. However, this cannot be kept for more than 48 hours because there is a high chance of granulation tissue formation around this fenestra. So this has to be used only in case of where we know that the upper airway is okay and the child has grown to a certain age where he will tolerate this kind of tube. Then there is something called as a capped polysomnography. So this is a kind of a sleep study done with a closed tracheostomy to see nighttime desaturations and apneic events in these children. So this is not done everywhere, but in special cases where we know that this child is going to have some problems in the night, we would advise that before decannulation, we should undergo a capped PSG. So final recommendations would be that safe decannulation can occur only after 13 months of age for a neonate. So we have to keep the child for a long time on this tracheostomy, hence the importance of good care, changing of the tube frequently, knowing all the complications associated with it. So if we have to try it before that, we have to use a 2.5 number tube, then do a microlaryngoscopy, cap it for 6 weeks at home, admit overnight, then try decannulation by strapping, observe for 24 hours, and then discharge. And all these parents have to be trained for basic and advanced life support after decannulation as well. So this is the overall summary of decannulation for these children. Now, there are certain post-decannulation complications like localized tracheomalacia, which I'll show here in this video. So after the tube is removed, we see that when the child inspires, this is the opening of the tracheocutaneous fistula. So more than 50% of the stoma is still blocked. So here we can't close this tracheocutaneous fistula, otherwise the child will collapse completely. Now, after removing of the tracheostomy tube, since we pinch the stoma and close by strapping, there is a possibility of this A-shaped deformity which does not present early. As the child grows, he starts developing exertional dyspnea. Then sometimes they can also have these tracheostomy tip-related distal tracheal stenosis, which is lower down. The stoma is closed here. This is the opening of the tracheostomy tube, and here is the stenotic lesion. So these can present later on after decannulation, and these are of course the suprastomal collapse and granulomas that can occur if we are not removing them and decannulating without an endoscopy. We see all these cause problems later on. So to conclude, appropriate tracheostomy steps with post-procedure care is utmost importance to be taught to all team members, not just the physicians, also the nurses and the family members. Decannulation protocols needs to be strictly followed in all the cases, and post-decannulation complications are also equally important and to be kept in mind. Hence, the follow-up of these neonates who are now post-decannulation should come back to the physician. Maybe they go back to the pediatrician, but they should be aware of these complications as well. Thank you so much for your patient listening. I'm happy to take any questions.
Wow, that was a wonderful talk, an eye-opener for all of us.
Thank you so much, sir. I hope I could put some light onto some important, relevant clinical topic.
Yeah, for most of the neonatologists like us, the initial stridor means laryngomalacia. So without thinking, without knowing anything, when the parent complains that the child has a persistent noise which is there all the time. So, and we just lazily say that it's probably laryngomalacia. And we are very daringly write it also on the prescription that, okay, he has laryngomalacia. So as a pediatrician, what do you think, like, what are the markers which tell that, okay, this could be laryngomalacia more likely, or if certain more other things are there, we can say this is unlikely to be laryngomalacia. So, and we should go for further evaluation. Because most laryngomalicias are not sent to ENT for airway evaluation. You just table them and say it will go away by 1 year, 1.5 years, and you just keep on waiting. So, what are the pitfalls in making such a diagnosis and the red flag signs? If
Right.
you could
So,
tell
sir,
us.
one first important thing would be the history, the way it presents. So, laryngomalacia, it will present not just at birth. It will slowly develop after the first 1 or 2 weeks of life, and then it will start to grow. The sound will start increasing, and the distress will also start increasing as the child's requirement increases. The retractions would increase. So, this kind of history that initially the child was okay, and then the noise started increasing is one red flag that should raise this possibility in mind. Second, the child improves in proning. This is another way of judging the history, that in prone position the child gets a little better. This is very important, that this may be not because any other obstructive lesion or a fixed obstructive lesion like vocal cord palsies or subglottic stenosis, which is the second and third most common cause of stridor in a neonate, they will not present like that. Third, if there is associated voice issue, then sometimes that means that there are vocal cords, there is a pathology at the level of the vocal cord. Then we know that this is not actually pure laryngomalacia, because laryngomalacia children should not present with vocal cord issues. Feeding issues, when they are associated, generally there is a overlap between reflux and laryngomalacia. So all children who have laryngomalacia have some degree of reflux. Because of the increased intra-abdominal pressure, they will have some degree of reflux. And all children who have reflux, studies have shown now, will have some amount of increased laryngomalacia. So children presenting with frequent vomitings and all, uh, generally the neonatologists or pediatricians would say this is because of reflux, but this will add to laryngomalacia. So such children should also be referred early for a laryngoscopy. Second, failure to gain weight. This is a very, very important history for us, because these are important surgical candidates. That is, failure to thrive is very important to us. Next important, so you have to always maintain that growth chart. And for after the first month, second month, third month, if the child is not gaining weight properly and has a stridulous breathing, then this child should be referred for an ENT evaluation. So these are what we look at when these children are referred to us, based on just on history and clinical examination from the pediatrician point of view. Dr. Bala, you
Excellent.
would like to add any other points?
If it's persistent, progressive, and there are problems with feeding and weight gain, then yes. And as Madam mentioned, positioning. If with position there is improvement, then it is something related to the larynx. If it is a static obstruction, it won't improve with positioning.
Okay. And vascular ring, any special thing to suspect vascular ring, because it is also probably easily diagnosable by CT or CT angio and
We
Yeah.
do not get a routine CT for any child. We prefer to get an endoscopy done prior to sending the child for a CT. There is no external signs that might guide you towards a vascular ring other than a 2D echo, as Dr. Kiran mentioned. On an echo, you might pick up, which is non-invasive, but if there is a persistent CPAP dependence, or if the child has V's lower down, then maybe you suspect that the obstruction is in the intrathoracic component of the airway.
So, I mean, yeah, just to add on there, like, I think one big take home from this message, this talk will be that, you should have a low threshold to do endoscopy and involve ENT. A lot of time, we neonatologists keep trying this failed extubation. We keep seeing maybe the lungs are bad, but a lot of time there's airway hidden, this thing. And when you work in a tertiary referral or quaternary referral centers, you get those babies who are stuck on the ventilator, and just we blame it on the lung parenchyma, but many times there is an airway issue, maybe one air bronchus issue or tracheal issue or subglottic stenosis. So I think high index of suspicion for the airway is very important, and then low threshold to involve ENT, and get a like good evaluation as expert, like two experts we have here. Lot of time the diagnosis clinch on the endoscopy. So I think that's one take home when everyone should take that, please refer and, try to get a detailed evaluation done.
Yeah, one more query for the ENT guys. Yeah, it's excellent presentation, wonderful cases which are shown here. I mean, a lot of problems which we face is, I think, the need for the appropriate size scope. I think, could you give us some guidelines of, I mean, the babies, I mean, what size scope is for what babies, and whether it is a prerogative of the pediatric ENT to carry everything, or because a lot of times we find that the baby is not appropriate size to insert a scope that is the given by the, because we get babies from 1 kilo onwards who require scope. Can you just make a comment on that?
So I'll let Dr. Anju speak first, then I'll tell my input.
Okay. So we have essentially two scopes that we have. I think only two scopes are needed. If you're asking for basic requirement of a scope in any pediatric center, I would say at least two is needed. One for the neonates. I feel neonates 1 kg, 1.5 kg, preemies and all, they can still easily take a 3.1 scope. After decongestion, they can take a 3.1 scope, though the suction would not work. It would be without a suction, but we can always suction through the opposite side, or we can suction through the mouth before inserting the scope. And another one, if you have, then it will be a flexible bronchoscope of 4.2 These are the two that with which you can almost deal with all pathologies. At least diagnostic scopies can be done for all cases. If you have smaller ones, it will be great. If you have larger ones, it will be excellent. But these two scopes are bare essential to start an airway diagnosis of an airway pathology. Dr. Bala, your inputs.
So you get portable ones of around 2.7, 2.8 but you do not get a suction with it. The clarity is quite good because they are chip-on-tip bronchoscopes. You can diagnose bedside with most of them, but suctioning becomes an issue in preterm and very small babies. For them, as Dr. Anju mentioned, you'll have to put through the other nostril, you'll have to put in an infant feeding tube or through the mouth. According to me, most of the dynamic collapses can be diagnosed with just an upper airway flexible endoscopy. Rarely you need to go beyond the larynx to look for any dynamic collapses in very small babies. Once the flexible is inside the trachea, the child automatically has increased stridor that can give a false sense of collapsing walls in very young children. So even if you can just see the larynx, that should suffice. Subsequent, if you're looking for distal airway anomalies, it's better that you do it in the OT with a rigid scope. So you should be able to see the distal ones, because most of the pediatric hospitals have a smaller caliber rigid scope. So you should be able to go beyond the glottis.
Dr. Balagopal, is it not mandatory that for severe cases of any, I mean, if you're looking at a supraglottic, I mean, even if you're looking at laryngomalacia, is it not essential that we go down beyond the larynx and look for other anomalies?
There can always be a secondary airway lesion. As I had shown in a couple of videos, our airway assessment does not end at larynx. So if it is something major, maybe you get a look at it, but you should always look for a secondary lesion, because when you go for treatment, you need to know the entire airway. You treat what is visible, you might miss out on something that is beyond. So you always need to see beyond the glottis to see if there's anything else.
And what is your take on, I mean, conditions like Pierre-Robin syndrome? When is your tongue lip adhesion or your distraction osteogenesis? When is what will be when will you advise and why? I think which one you prefer doing, because our people
there are
prefer.
no credible studies saying something is better than the other. It has to be a multidisciplinary approach to it. We involve our plastic surgeon, we have our neonatologist, we have our speech language therapist. We see what the child has, if it is primarily respiratory issue, if it is swallowing that is an issue, if it is ventilator dependence that we are dealing with. So if we do an airway assessment, the least invasive thing that we can do is a tongue lip adhesion. So we always go in favor of that because it's reversible. After 6 months, you can remove the suture and the child is almost back to normal. But if the child is even after tongue lip adhesion, the child is not doing well is when we think of subsequent higher invasive surgeries. I hope I answered.
Excellent. Excellent. I have a couple of questions which have been SMS to me. And if I could read them out, one is LMA. So Dr. Anju also talked about LMA usage in emergency and all. So what size as per weight? Like, so we have normally neonatologists know, okay, what ET tube to put in based on the weight of the baby. So which LMA size are the different sizes of LMA? And as per weight, can we use one number or the other?
Yeah. So there are sizes available. There are neonatal as well as pediatric, and there is a chart which I can share. There are different types of supraglottic devices which the anesthetists usually have in their trolley in any pediatric hospital. So we can get from them, or in our neonatal setup, we have those LMAs kept ready. So these are different types of supraglottic devices like iGel, first generation, second generation. So these can be used easily. Uh, Another thing that can be done in these cases is if your bag mask is getting difficult, then you can intubate using a fiber optic scope, which is called a hybrid technique to intubate, which means that we pass the flexible scope through the nose, and the anesthetist tries to intubate with his laryngoscope because he's not able to see the airway properly. So even that can be tried for intubation. So these LMAs also have a channel for a flexible to be passed. So you can continue to ventilate through the LMA and pass an flexible scope, and then you can intubate after removing under vision. So it's called the hybrid technique.
Thank you. And another one very interesting question I received is, if you have a atresia and you just can't put in a tube, so how difficult it is for a cricothyrotomy to be done by a pediatrician or a neonatologist if ENT surgeon is not available at that time?
Okay. So cricothyrotomy is actually not recommended in less than 8 years of child. 8 years, because the cricothyroid membrane is not well developed. In that case, transtracheal puncture can still be tried. A transtracheal puncture, because you will not be able to palpate the landmarks that well. But if you are able to palpate, in these case of tracheal agenesis, on the laryngeal and the cricoid and everything will be stenosed. So there will be no airway from the above. What you can do, as Dr. Bala said, that you can pass a endotracheal tube into the esophagus. Usually they have an associated TO fistula, PE fistula. So they might get partially ventilated through that TE fistula temporarily. Till then, you can do a transtracheal puncture and aspirate. And if you get an air, you open at that area and pass a small endotracheal tube from here. If it's a long segment of agenesis, then it would be nearly not amenable to life, and we will not be able to do it. But generally, what common anomalies that survive, they come to us is generally up to the upper tracheal level. So these lower tracheal levels are still palpable, and we can do a transtracheal puncture.
If it is glottic web that you are asking, sir, most of the times they are ventilatable. If it is glottic webs, even type 4 is they can be ventilated. Obviously, it's better that you do not attempt to intubate if the tube does not go in the first attempt. So once there has been a failed attempt, it's just better to mask ventilate in case of laryngeal atresia. Not agenesis, laryngeal atresia.
So there is a
laryngeal
spectrum.
webs.
Yeah, there is a spectrum from laryngeal webs 1, 2, 3, 4 to total laryngeal atresia, and then tracheal agenesis. So tracheal agenesis is essentially not amenable to life. I mean, it's not that nobody has attempted to operate on such a case, but there are only 6 reported cases of successful surgeries. The number is very few, and the prognosis is very poor. So generally in our country, if you're able to intubate into the esophagus and with a TO fistula, if the child survives, then at least you'll be able to diagnose with a scan. Otherwise, it's very difficult to deal with these kind of children.
There's a question in the chat box. Can I take it up, sir? I think.
Yes, sir. Yes, sir. Yes, Dr. Giridhar.
Yeah, I think there is a question regarding need for GER prophylaxis in laryngomalacia and how long. I think not only laryngomalacia, most of the conditions which cause upper airway obstruction the ENT people advise us to start them on GR prophylaxis, especially if the obstruction appears to be severe. So what is your take on this?
Yeah, so Dr. Bala, he's doing a study on this, on laryngomalacia and GER. Dr. Bala, can you take this?
We give it up to first 3 months and then we reassess. In the first 3 months, if the child is nearing a normal curve of growth, then we consider stopping it. We are still not through the study, but maybe at a later stage I'll explain the findings.
So I think there's only one question there in the chat box. So any other questions?
Yes, somebody is asking for that app.
Yeah.
There are a couple of apps. One is mobile Airway card, and there's one from Thailand as well. It's called Pediatric Airway app. I think. You just type Airway on Google Play, you get these Airway cards.
And I have a question for the tracheostomy care. I think once we keep adding the HMEs to the track tube, invariably the dead space increases. Sometimes we see that the kids land up with a lot of retractions after the HME. So I think if you are advising only wet saline gauzes to be placed on the opening, if you want to, if you keep advising, give patient education means how frequently you'll ask them to keep changing it, because there is a chance that again infection could happen because of this.
Yeah.
And is there any smaller size, which is the least size one which covers the least dead space? Any newer device has come up?
So we have that HME filter. I do not know the company, but I can let you know through the hospital what they have. In our neonatal settings, they do not find it difficult to keep that, because we keep it for all the patients. Only after the first track change, if the child is comfortable and off the venti, then we advise those wet gauze, because then the child goes to the parents and then they have to deal with the child themselves. So then it becomes easier for them to change the gauze. So there are ready-made now track care sets available, which contains all these velcros, these dressings, these bibs, small bibs, ventilatable bibs, which are made of mesh for neonates as well, which are colorful designed and all. So we ask them to keep it moist all the time, but it has to be changed at 8 hourly interval, and it has to be cleaned very nicely. And usually, maybe there is a bias. If Dr. Bala will say he comes from a background of municipal cases, where I am into a private setup, so maybe the chances of infection in his cases are more. But at least in the private setup, we don't see so many of tracheostomy related infections and care related infections. Dr. Bala, you have your own take on
Cost is also a factor.
Yeah.
Each thermovent costs about 250 rupees. So we ask them, as soon as the mother is able to take care of the child, we ask for them to put a mask, a simple cotton mask. We ask them to tie rather than a bib. Many of them are from villages, so we ask them to buy a couple of masks. As soon as it's soiled, clean it, dry it in the sun, and reuse. So that has been working for us.
Okay, I had a query as a clinician that in subglottic stenosis after prolonged ventilation, and is there any duration after which you say that okay, if you have ventilated a newborn for more than 1 month, more than 2 months, you should go for tracheostomy. Adults are very rapidly into tracheostomy. I see road traffic accident, second or third day on ventilator, they put in a tracheostomy tube. Okay, it is easier to manage airway and ventilation with the tracheostomy. So, any recommendations you have for prolonged ventilated newborn babies, preterm or term babies?
Our
Dr. Bala.
threshold is quite high. We wait for months, especially children with BPD. We have had children for almost till the child is of term. For a few months, we have been able to ventilate with no major issues. So, as I mentioned, neonatal cartilages they are very flexible and they can withstand quite a bit of trauma without major consequences. Dr. Anju or Dr. Kiran.
Yeah. Yeah, so 3 to 4 months is the time. I mean, I think 4 months would be the maximum that I have heard of and read about. But around 3 months is the time in our hospital as well, where we would then the neonatologist would call for a track. At this stage, we can also say that even if we have these children coming to us for a track after a very prolonged intubation, when we remove these endotracheal tubes, we always apply steroid to the local area. So Dr. Bala and myself, we have actually done this to all patients who come for tracheostomies. We would assess them endoscopically in the OT, just a quick scopy and applying local steroid on a patty, or maybe Dr. Bala also keeps the whole area filled with kinacort, which is triamcinolone. This acts locally and it prevents those airway related endotracheal tube related injury going into the stenotic lesions. So we have seen amazing results with those. So maybe our threshold can increase even further if we take care of these post intubation injuries early on.
So
Correct.
if there are extubation failures in a preterm baby and with the associated stridor which is there, so that means that subglottic stenosis is becoming significant. So what would be the indication for tracheostomy in such a baby who is having repeated extubation failures with stridor? And so when do you say, okay, let's take the baby for tracheostomy in such case?
So after 2 extubation failures, we should always call for an endoscopic assessment to check the subglottis. Ideally, if in ideal world where and internationally as well, the recommended case is that after each extubation you should do a scopy. But obviously, it's not possible in our cases. So we recommend that after 2 failed extubation attempts, you take the patient to the OT, extubate in OT, pass a flexible endoscope, check for airway lesions, remove all the granulations, apply steroid, pass a smaller endotracheal tube. Like if the child was on a 3.5, you put in a 3, apply steroid on it, intubate for 2 or 3 extra days, and then extubate again. And this steroid will act locally, and then many cases will then get extubated. So we don't recommend tracheostomy after 2 failed extubations as well. Unless we have attempted and failed at this once.
And does this work the same way? How, I mean, how is it going to be different from giving your inhalation budesonide or nebulized budesonide?
Yeah. So absorption rates, absorption rates of of steroids when it acts locally on an inflamed area is going to be lesser, obviously. But we are applying directly locally, and it stays there for some time because we are keeping the endotracheal tube as a stent. So it will stay there for some time, and it will get absorbed directly into the inflamed tissue, and it will act better. So this has worked very well for all these prolonged and recurrent failed extubation cases. So we've avoided many tracks. Though I must not say that all can be avoided, but if after this one attempt of applying steroids, we extubate and we see that it is coming back again, still we would try and first dilate a little bit and give a good airway and try to give BiPAP, NIV, and try to see whether we can avoid. Doing a tracheostomy is the last thing that comes on our mind for such cases, for post-intubation injuries.
So can we simply instill triamcinolone through the endotracheal tube and just so that it goes locally and acts over there? Is that a possibility?
It
But
needs
lift
to be
inside the tube.
it needs to be at the subglottis and the glottic level, so it shouldn't go beyond through the endotracheal tube. In fact, I was just coming to say that our PICU people, they have started applying triamcinolone on all their endotracheal tube and they intubate. They're like, even if it gets injured, we have a cure for it. So
Yeah, instead of a jelly, it will act as a lubricant as well as a preventive measure.
Correct. And tracheostomy, I think even in the best of the center is generally avoided, as everyone rightly said, because the outcomes are not great. Even, I think the survival with the tracheostomy at home in the hospital is very low, even in best of the centers. So we try to avoid. So that's why we are moving towards more NIV. We try to give steroids and extubate them early and keep them on NIV. Sometimes some of these airway babies are also managed on high dose of NIV. You don't have to always intubate. So we had those airway issues where we just give higher PEEP and let the trachea grow and let the baby grow, and then they overcome. It's just a matter of patience and using steroids and sometimes positioning and give time to avoid trachea. So that's the way forward, I think. Great. I think
We'll wind up.
yeah, we
Yes.
covered, I think, great. I think Dr. Bala and Dr. Anju, we covered, this is the whole complete new gamut of, airway issues. And it's very interesting, what new anomalies we can find on those referred cases. So really interesting discussions. So should we close?
Yes, sir.
Yeah.
Yes, sir.
Yes, sir.
I hope we made a justice to the
Oh, it was wonderful.
Definitely,
And
definitely.
thank you,
Wonderful.
Dr. Kiran, with your experts. It was wonderful for all neonatologists to listen
So
to.
eye-opener for all of us, actually.
we got
Yeah,
it was
definitely.
the best from Mumbai for you all.
Oh, yeah, it was best of Mumbai. It was better than Bollywood. The stars of neonatal ENT and neonatologists. So it was wonderful. Thanks from on behalf of NNF. I
Thank
would
you.
like to extend our
Thank you,
thanks
sir.
and thank you, Dr. Giridhar,
Thank you,
for
sir.
being
Pleasure
here
is
and
yours.
giving your insight. Thanks all the audience who have patiently stayed over for extended session. Thank you very much.
Thank you.
So
Thank
good
you so
night,
much. Thank you.
everyone. Thank you. Thanks for the
Good
wonderful
night.
session.
Good night.
Bye. Good night.
Bye. 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 Recording there, then, if you can have a recording, I think it's nice.